favorite life.
All right. Again, welcome everyone. We're so happy to be in Monica's space and to be amongst all of you all, because this is a blessing for sure. I'm going to use some good oxygen here and let you know that Dr. Jack and I are so very happy to have this opportunity to share something that we feel is very impactful in not only our patients, our friends. I wish we could reach out to more friends. I was telling Dr. Lewis, I got a little sidetracked with committing to a response to him because, you know, I find out every other month or so, you know, we're much older than all of y'all, but people are dying and it's unnecessary. And I wish that our words would have been maybe more resonating, or that people just don't settle for the conventional sick care model that most of us are exposed to, that now are making a way into looking at other alternatives, because that's what we want to provide our patients, our family, our friends. So it's just been a little hard. I just lost another friend who's 2 years younger than I am, so he died at age 66. But back in 1999, Dr. Jack and myself, we were talking about moving into that whole anti-aging medicine, no such thing. Then the powers that be termed it age management medicine, which is truly what it is, because we can't defy aging, but we can get there gracefully. And then because anti-aging and age management medicine, the syntax sounded so very similar, the powers that be transformed that particular title to the practice of wellness medicine. Now that's a very broad adjective, what we agree. So then I guess about 15, 16 years ago, the term became lifestyle or functional medicine, getting to the root cause of a disease instead of, chasing a symptom and, writing a prescription, giving it to the patient and say, I'll see you in 6 months or so. So we've adopted the term longevity or regenerative medicine. So I want to give Dr. Jack all the credit for our practice, and that is we are considered paradox biorejuvenees. So again, paradox biorejuvenees. So paradox meaning that we are a paradox, or two physicians, that we practice paradoxically, and that we listen to our patients, and again we get to the root cause of any disease or disorder. Biorejuvenees is the science of maintaining a youthful life, and we're in Louisiana, so we had to have a little en français. Oui? Okay. Merci beaucoup. So anyway, I told Abby that I would introduce us, because Dr. Jack is going to be the real lead in this presentation. Y'all know I like to talk, but not so much tonight. So anyway, we, Paradox, we are Dr. Karen Pendleton and Dr. Jack Ward, and we consider ourselves, and we've been considered innovators in optimal health and longevity. And then for over 40 years, or 4 decades, same thing, we've both been respected members in the healthcare industry. We both have established ourselves as leaders in promoting alternatives to the conventional medical model of sick care. We're all about well care, right? So together, we've had a keen understanding of how to personalize medical care for each of our client patients. And so we take this patient-focused approach, and that has really earned us a special place in the healthcare industry that we rotate through. So both of our patients are either athletes, business owners such as yourself, or everyday folks who are really frustrated, and I say it again, frustrated with the conventional sick care model. And these are people who really want to achieve more out of their life with purposeful longevity. We hear time in and time again that patients are not feeling seen, they're not feeling heard, and definitely not feeling valued. So along the way, both of us have developed these proprietary protocols to build effective longevity and to ensure people that they have the best health available. we have a program in our practice called Purposeful Longevity, and we help patients or people match their lifespan, which is your years of life, with your health span. And your health span is your years of life, but living that life with joy, love, vitality, and blessings. And what we currently know is that for most senior citizens, there's about a 13-year discrepancy between lifespan and health span. So we're here today to help our patients match those two entities. So finally, I want to say that, both of us are continuing to work on our work-life balance. And so, we want to make sure that we spend quality time with our family, our friends, our NAHA members. So we find that, that's our struggle at times, but we're getting to a point where we find that we can get that on cruise control. And then finally, both of us are physician leaders in heart health and longevity. And we spent over these 40 years taking care of patients. Dr. Jack received his degree from LSU in Shreveport in 1981. I received my medical degree in 1984 from Tulane. But really for the last 25 plus years, this has been our dedication. You're looking at a gentleman that has a 94 to 96% survival rate. He's an orthopedic cancer surgeon. And I, in my traditional role, was a corneal transplant surgeon. So we used to wear two hats, but now our hat is strictly this longevity, purposeful longevity, I should say. So without any further ado, I thank you for listening to this voice and for the introduction that I made for myself and Dr. Jack from the directory. Thank you. One more thing, we have something that we're going to talk about, but save the date, Thursday, June 18th, from 8 until 12. This is kind of like the springboard in which we utilize the information from this very sophisticated ultrasound of the carotid arteries to determine one's risk for heart attack, stroke, and dementia. It's more than just the heart. I mean, the heart depends on its ability to pump. It's the most important muscle in our body. But without those 30,000 miles of arteries, did you hear me? Miles, 30,000 miles, not 30,000. The heart wouldn't have anything to pump. So this is a really important ultrasound. It's called the carotid intima media thickness. The acronym is CIMT. It's a 15-minute, non-invasive, don't even have to take your clothes off type of ultrasound. And it's looking at not just blood flowing through the lumen of the artery and at what velocity, but it's looking at the health of that inner wall and that middle wall. And what we know is when the wall of the artery is inflamed, it becomes a magnet attraction for that LDL, that lousy bad cholesterol, to set up plaque. So I just wanted you all, it'll be on our newsletter tomorrow, and it's an investment in your health. So that's what I wanted to share. I will sit down. Thank you.
Wait, how do I do this, Kim?
From the beginning. There you go. Oh, take off the CC.
The what?
It's going to start.
Oh yeah, thank you.
Yeah.
Appreciate
See?
that. New technology. I haven't figured out how to not have it record my voice. So I've been studying longevity since I was a teenager. So that's probably a long time before most of y'all were born, and probably, it was in the last millennium and the last century. So, sorry about that. When I was a teenager, I just saw a program about people living to be 100, and that just fascinated me. And I was already a pain in the ass to my mother because I didn't eat eggs. I did eat, and I couldn't stand cakes and stuff. So like when everybody had their birthday parties, everybody had a cake, but I had a big, huge fruit bowl. So that was my. And then when I was at De La Salle, nobody liked to eat salads. So pretty much at 30 minutes in lunch, I'd pretty much eaten about 50 salads. So that's my story about being healthy. And then I went to medical school, and they didn't teach me anything about nutrition. So then I had to learn it on the side while I was there. So how many people here have lost somebody to heart attack, stroke, or dementia? Almost everybody in this room. So let's see the next slide.
Okay.
Dr. Karen and I know that a heart attack is preventable, and we've identified 9 tests that we can prove that it's preventable. Next slide. So Marcus was a 46-year-old businessman. He loved his family. He taught he was a soccer coach for his daughter. And then one day he collapsed and died from a massive heart attack. 3 months prior to that, he had seen his doctor, and his doctor told him he was fine. Was his doctor wrong? Probably not, because it was really the wrong tests that the doctor was using, and it didn't give him the answers that he needed. Next slide. So really, when you go to the doctor now, because we hear this, the standard checkup is broken. It's pretty much looking at cholesterol, glucose, and blood pressure. But we know that there's more going on in the blood vessels, and it's called inflammation, than what's being tested.
Yeah, Monica mentioned inflammation. Inflammation is a root cause of all diseases and all disorders, whether we talk about cancer, diabetes, heart disease, thyroid issues, just to name just a few.
So we have 3 pillars we look at. We have 9 tests within those pillars, and then we have 1 conversation with the patient. So our pillars are genetics, and that's the cards you are dealt with. Now, the cards you are dealt with doesn't necessarily mean that they have to, impact your life. You can do things to affect your genes. Inflammation is what we actually know is going on in the blood vessels, and then nutrition is what happens to the food that goes into your body. Next slide. So on the genetics, which is the cards you were dealt, we look at 3 genetic markers. We look at the ApoE gene, we look at the heart attack gene.
Did y'all know there's a heart attack gene?
What is that? What's it called?
He's going to talk.
The 9P20, it's called 9P21. and then we look at LP(a). So the ApoE gene is a unique gene, and it really kind of defines what type of food we should eat. And there are 3 variants, and there are 6 copies of the gene, but there's a 2-2, 2-3, 2-4, a 3-3, a 3-4, and a 4-4. But we pretty much narrow it down to 2, 3, and 4 because it's the 4 that is important. Now, the majority of people, about 65%, are going to be 3-3. And from a standpoint of nutrition, they can eat just about whatever they want. We prefer it to be healthy, maybe along the lines of the Mediterranean diet. The 2s represent about 5 to 10% of the population, and they actually do better with fat. And I happen to be a 2. And so, Karen used to give me a hard time. She said, "You're eating too many nuts, you're eating too much fat." And then we got my genetics, and I said, boom. and then the one that's really a challenge, and they represent 25% of the population, is the ApoE4s. And so they have a higher risk of heart attacks and heart attack disease and Alzheimer's disease. And Dr. Karen happens to be a 3-4. And for that group of people, they really need to limit their fats to about 20 to 25%. So if you don't know your genetics and you're on a ketogenic diet and you're an ApoE4, you are working on killing yourself.
So when Dr. Jack says 3-3 or 4-3 or 2-3, you get one of those genetic markers from mama, you get one for daddy. So I'm a 3-4. Because I have 4 in my genetic makeup, that makes me a 4. So I know that my mother is a 3, so I got that from mama. My daddy, I didn't know about all this genetic, these biomarkers before he died at age 75. So I'm assuming he was a 4. So as a 4, again, in my lifetime, I'm at a greater risk for developing Alzheimer's disease. As a 3-4, I should limit alcohol. I have some patients that are 4-4. That means they got a 4 from mama, a 4 from daddy. Alcohol is a neurotoxin. They should not let that touch their lips. So that's what I wanted to say.
Thank you. And then on the heart attack gene, so you can have no heart attack gene risk. You can have one copy, or you can have two. If you have one copy, there's about a 1.5 fold increase in heart attacks, and then a two is if you have both copies, about 2 times. But just because your genetics point that out doesn't necessarily mean that you're going to have a heart attack if you have the heart attack gene. Again, I'm blessed because I don't have a copy of the heart attack gene, but Dr. Cameron has a copy.
I got all the genes. But genetics, yes ma'am, I'm gonna get you. Genetics, as I was telling Abby, and I tell patients with Dr. Jack every day, genetics only plays a 20% contribution in that can manifest in us. 80% is environmental. So it's the choices that we make in our lifestyle. And you had a question?
I was wondering if you found a trend of maybe where the genetics are coming from, like a regional decline with that getting the 4.
Not necessarily.
What was the question? Just if there's a correlation of like regional, where maybe going back to our ancestral like means.
But I know what you're certain genetics have like a regional or like a ethnic. Yeah, no, it's a little bit different.
Okay.
Is there any correlation, the whole thing about eat right for your blood type?
Right,
Does this
okay.
fold into this at all?
So I would say yes, but if we look at that, the original blood type was type O. Karen's a type O, and so she's a pure hunter-gatherer. So she would really benefit from eating more meat and
Animal protein.
Forest stuff. And then, type A it came about when it was an agricultural. Now, realistically, if you listen to Dr. Lufkin, who wrote a book, The Lies I Told in Medical School, he I was there, not with him, but anyway. So that came about when agriculture happened. But what actually happened with agriculture was we narrowed down our food choices. So we pretty much had corn, rice, and wheat. Whereas if you look at the hunter-gatherers, they were out there having to forage, so they had access to about 65 to 100 different types of foods to eat. So, and then the bees came about when the agricultural areas were getting crowded, so they moved up the mountains, and then they started raising sheep and cows, and so they're probably the natural cheese milk eaters. Whereas the other milk is probably going to cause O's and A's inflammation.
So it does play a part in your findings, the blood type for your diet?
Yes, right. And it helps to guide nutritional, plans too. So, and then the LP little a, which is called lipoprotein A, the body makes lipoprotein A, but there's some people that have a propensity to have more of it, and it actually causes inflammation in the blood vessels. Anybody here ever watched The Biggest Loser? Mm-hmm. So Bob Harper, here's this guy, if you look at him, picture of health, exercise and everything, and he gets a heart attack at 52. And it's because of his genetics and because he's got a positive LP little a. The interesting thing is you can't really control the LP little a with food or exercise. However, what we have found, particularly in our practice, if a woman has elevated LP little a, we have some cases where when we put them on estrogen therapy for a hormone replacement, it has normalized their LP little a. So there's some benefit to that in somebody that has LP little a.
And also, it's very responsive to baby aspirin. And the other thing about Bob Harper and he's the spokesperson for this one particular biomarker. So when he recovered from his heart attack, they brought in all of his first and second degree relatives, like his parents and siblings, maternal and paternal grandparents, and 2/3 of his family had an elevated lipoprotein little a. So by just doing that kind of, proactive, preventative investigation, more than likely those relatives were spared having a heart attack. So that's really important. Go ahead.
So give them, the protocol was estrogen, right?
If
Right,
needed.
we have found that estradiol works. If a woman has LP little a, we just found this out because we were treating them for their hormone deficiencies, and it just so happened that they had elevated LP little a, and when we retested them after they were on the estradiol, it normalized. So that's
So do you educate like on food, because flaxseed helps with our estrogen. So if we're low on estrogen, we should be eating flaxseed daily to up our estrogen in our body. So you're using that first, or you go into a pharmaceutical? Estradiol.
it depends.
And we don't use pharmaceutical, if you will. We use bioidentical hormone replacement therapy, but it's such a challenge, but it's a wonderfully received challenge that we have, because every patient is individualized, and so we obviously we take a personalized approach. So if that patient is like an APOE4 like me, where only 20% of my calories can come from healthy fats, I've got to modulate that flaxseed and that flaxseed oil. So we have to find some balances in the tools that we institute in that particular patient. But that's a great point.
Yeah, and all of it comes down to inflammation or the fire that's going on inside the blood vessels. So we have a lot of tests, but these are our three basic tests. The HSCRP, which is a highly sensitive CRP, it really is broad, and so if it's elevated, there could be inflammation anywhere in the body. So we also use we also use LP-PLA2, which we call it plaque 2, and then myeloperoxidase, or MPO. And those really give us a better sense of what's going on in terms of inflammation in the body. And if both of them are elevated, we really have to find out where the source is. And a lot of times where the source is coming from is the oral cavity. So then we get down to nutrition. So what is your food that you're eating doing to your body? So we use three things, like the ApoB. So everybody harps on LDL, particularly if you're going to be treated with a statin, they harp on LDL. The body needs LDL, and then there's LDL, and then there's bad LDL. There's HDL, but there's also bad HDL, and a lot of doctors don't tell patients that. The test that we use is apolipoprotein B. So it's really a suitcase for LDL and HDL, and then it'll go through the wall of the artery, but if there's inflammation or it gets trapped, it's going to drop the cholesterol into the blood vessel. The other test we use is oxidized LDL. That's really the bad form of LDL. How many people here have had an elevated LDL, but have you ever had an oxidative LDL test?
Probably not.
Probably not. And then fasting glucose. So, fasting glucose just gives us an idea of inflammation, and it's probably related, that's if we have high inflammation, we got elevated glucose, we're probably working on insulin resistance. So getting to what Monica does, we were talking about stress and inflammation. So I had my, hemoglobin A1C tested back in November, and it was like 5.2. I just had it tested 2 weeks ago. It comes back 6. But the amount of stress that I've been over for the past 6 months, the amount of driving I've had to do going up and down Shreveport, so it took away from me doing the amount of exercise I did. So I didn't have the exercise to drive down my stress and so I got to really work on that now.
And normal hemoglobin A1C is less than 5.7. Okay.
So heart disease doesn't ambush you. Now, a heart attack will ambush you, but heart disease takes about 20 to 60 years to develop. And that's the part that's really being missed. So we have 3 different stories. We have Marcus, who didn't have any testing, and he died of a heart attack. We have Barbara, who's 68, which is really Dr. Karen, who she has all these genetic risks, but because of her lifestyle, the her
I'm
habits.
still here.
You know, everything loaded the gun, but her lifestyle kept the safety on. And then David is a 48-year-old who came to us, and he has some things that we found, and he's initiated therapy, and hopefully we can change the direction of his life. So your genetics load the gun, your lifestyle pulls the trigger or keeps the safety on. So you don't have to be Marcus. We have 9 targeted tests, 3 pillars of prevention, and 1 conversation that could change your life. Now I gotta pull up the other thing.
Okay. So
But we're still not. We're still working.
that's part A. We doing good on
How are we
your
doing on time?
Mhm. Yeah. Yes.
So genetics, how old is your mom?
94 and a half. Yes. Not 94, but 94 and a half, sister.
And she's living
Yes.
independently, right?
Yes, independently in Shreveport, and she's on Facebook, and she's an influencer, she told me, and I'm like, oh, yeah, I saw a hand out there, but let me tell you something else. Okay, so my grandparents married, and they had my aunt, my mother's older sister, and my mom. My grandfather was an only child, and he was Mr. Leroy Chocolate. So when my mama left Shreveport to come to New Orleans to go to undergrad at Dillard, when she met my daddy, Lewis Pendleton from Monroe, she was Barbara Chocolate. And so everybody loved Barbara Chocolate. But anyway, my mother said to me, "Sister," I said, "Yes, ma'am." She says, you know, you have me so healthy," because she's a patient, and she's a very compliant patient. She says, "You have me so healthy. I hope I don't outlive my money. You know I'm a depression baby, and I worry about that." I said, "Well, Mama, listen, I know you and Daddy made some good plans, so I tell you what I'm going to do for you." And she said, "What is that?" I said, "I'm going to get you to 100, but then after that, you're on your own." And she tapped me on my butt.
Yeah.
That's my mama.
And speaking of chocolate, so we decided to do this month, and about a month ago we were thinking about what in the world are we going to offer, and then we happened to be in Whole Foods, and I saw this company, Blue Stripes, which their products have about 70% cacao, but it's really well-sourced cacao. And I thought, well, we're just going to do something different. We're just going to offer healthy chocolate. So I'll let y'all pass these around so you can see the different things that are out there, and they have different products. And
But don't be
one thing you
fooled.
have to be careful of if you're getting chocolate is companies have figured out, because cacao is so expensive, that they can make a synthetic dark chocolate. So it's pretty much going to be with palm oil, cocoa butter, or something like that. So when the label says 70% cocoa, you got to really throw it in the trash.
So your protocol, the 3 steps, right? The package deal. What does that package cost?
So the carotid intima media thickness ultrasound.
Or just all the different blood tests and all that
Mhm.
package?
So, but we either start with the blood work, or we start off with understanding what those arteries are doing. And because the carotids are so readily accessible right here, whatever we are able to determine based on the ultrasound, we can say is more than likely happening in those other 30,000 miles of arteries. So that testing is $300, but that affords the individual an opportunity not only to have the ultrasound, but also the 30-minute follow-up to go over the report and what it truly means and what the next steps are or are not. The blood work can be done either out of pocket through a dry blood spot or an actual, blood draw. We're very seasoned in our ability to do the coding for our patients. But if you're, 65, or if you have Medicare covers everything but the genetics. Each individual genetic testing, the first test is $50, and then each additional beyond the first is $25. And we typically order about 6. We wanted to kind of prioritize those first 3 that Dr. Jack spoke about, but for $175 or so, you will have all the genetics that you'll ever. And you know what? One time you do the genetics, that's all you have, because your genes don't change, right? So it's a one and done kind of test.
So Medicare covers a good bit of that, but genetics.
Yes,
Right.
and you know, if someone really wanted to pay out of pocket, I tell patients it's one stick, but it's about 33 studies, so it's about 12 tubes of blood. The turnaround time, it's through the Boston Heart Diagnostics. The turnaround time is about 10 to 14 days. If someone really wanted to write a check or give their credit card, that's about $5,000 worth of blood work.
So, but otherwise you take insurance?
The lab does.
The lab does.
We're concierge, so to speak, and I don't really like to use that term, but we are very, very concierge-like. Go ahead.
And part of the reason why we don't take insurance is because what we've found in our 25 years of doing this, insurance gets in the way of us changing somebody's life. Now, we will, you know, if we have the diagnosis of, you know, something in the carotid arteries and somebody has insurance, then we have a code, and so we can get all that lab covered if we have a code, except for the genetics. Almost nobody's covering the genetics, so.
Thank y'all for what you're doing. It's good.
Thank you.
Anyway, so anyway, as the cell goes,
Navigating the matrix.
Yes,
Right.
that's what it is.
so as the cell goes, so goes the body. So, you know, it's all about cell function and cell dysfunction. So just about everything we do, even sitting here listening to us, walking around back there to get some water, you know, causes inflammation, or it causes oxidative stress, which then leads to inflammation. And, you know, doing yoga helps to calm that oxidative stress, and doing some other things help to calm it too. So oxidative stress. So if you have cell dysfunction, you're going to get arterial disease, dementia, cancer, diabetes, and shorter health span. And so what we're looking at is we said there's 30,000 miles of arteries. There's another 30,000 miles of veins. So there's really 60,000 miles of blood vessels in the body. And what we're looking at is what is the oxidative stress causing to that tree, and can we identify fire in the tree? And we know that this is the root cause tree. We've identified that there are 20 things that we know of that cause oxidative stress and inflammation. Some of them are going to be low vitamin D, some of them are insulin resistance, the myeloperoxidase, the LP(a).
Not getting 7 to 8.5 hours of uninterrupted sleep, or the most profound representation of sleep fragmentation is sleep apnea.
And then the biggest one that, you know, it's finding those dentists who understand this is the oral cavity.
Mm-hmm, mm-hmm.
So you want to cover this?
Okay,
Oh,
so you can press on this as I go.
yeah.
So just for orientation, you know, this is my artery, and this is an artery that we don't want because it's got a lot of plaque. So this is the lumen of the artery. I love it when patients go, oh, Dr. Karen, Dr. Jack, I've had that ultrasound of my carotid arteries. And again, as I was being very dramatic, I said, well, that's a Doppler. I never correct the patients. I'm like, that's great that you've had that particular ultrasound, but this ultrasound is looking at the health of the wall of the artery, as opposed to what you might have had, you know, in another setting that's looking at blood flowing through the lumen, and this is the lumen, and at what velocity, right? And we would all agree that blood can flow through this part of the model of the artery and this part, but it's a no-brainer. We want this part. So we want to make sure that the wall of the artery is healthy. So we talked about the ApoB, and that is the extra suitcases of cholesterol that are attached to the LDL, the lousy, and the HDL, the happy cholesterol. Well, with oxidation or inflammation that Monica was talking about, that's going to allow that extra suitcase that's on that LDL particle to get into the wall of the artery. So then it gets trapped, you all, and then it starts over time, because it's not supposed to be there, it's going to incite more and more inflammation. So
and it's carrying the cholesterol, so when it's trapped inside the blood vessel, that's when you have cholesterol inside the blood vessel.
And so there's a fine little layer of cells that lay on the inner surface of the inner wall. It's called the endothelium. It's a one-cell layer, and that's the layer between the healthy part of the artery and something that's occurring with oxidative stress, or i.e. inflammation. This takes anywhere, as Dr. Jack mentioned, anywhere from 20 to 60 years. And then as we go further, because you haven't seen us, I'm just teasing, but anyway, yeah, more plaque grows. And that may take us into even more inflammation, and it's worsening that area. Again, the lining, and we get to 3 to 10 years. And then if that plaque has an opportunity to rupture, it's going to release all of those nasty LDL, ApoB particles. And as blood is trying to float through the lumen of the artery, it encounters this rupture. That blood gets kind of turbulent and it gets clotty. And so if you have this much plaque, you throw in a blood clot, it's going to further compromise flow or totally occlude flow. And if that's happening in our carotid arteries, the event is called a stroke. If it's happening in our coronaries that service the heart muscle, that's called a heart attack. So that can happen in 1 to 2 minutes. And then what can happen in about 30 minutes to 2 hours, the heart muscle will start to die. And then the brain, it's not as forgiving as the heart. In 3 to 4 minutes, we have a stroke.
So when we're using the CIMT, what we're looking for is soft plaque. And that's really the only test that will help us find soft plaque, short of blood work that will tell us something's going on. You've probably heard of the coronary artery calcium score.
Yeah.
Well, what that's doing is that's measuring calcification in the plaque. And really, when it's calcified, it has healed. So, and then they talk about, the more calcification you have, probably the more healing you have. But what we're really concerned about is what's right next to the calcium, which is going to be soft plaque. And just because you have a negative calcium artery score doesn't necessarily mean you don't have plaque in your blood vessels.
Yeah. So the CACS, the coronary artery calcium score, I've had patients say, "Oh, Dr. Karen, I got a 0," or "I got 10. That's a low number." Yes, that's good. That is exactly what Dr. Jack said about the fact that that plaque is calcified. It is healed. We have 3 forms of plaque. We have soft plaque, and then on the opposite end of the spectrum, we have the calcified plaque. And then the third form is a mixture of a little bit of soft, a little bit of hard. When we hear the word soft, it conjures up, gentle thoughts or, a good thing. And we hear the word calcified or hard, that's evil or that's bad, but it's counterintuitive. Soft plaque, just like a pimple, could rupture. And just as we've explained to you all tonight, that it's that soft plaque that's dangerous. So on that calcium score that's either 0 or a very low number, it speaks nothing to the evidence of any soft plaque, which is the dangerous plaque. So someone could be walking around and feel very confident in their score on that calcium score, when indeed they are possibly a setup for a heart attack or stroke. And that's where the CIMT can distinguish soft plaque, hard plaque, and the mixture. So that can be a full evaluation as opposed to the CACS, which is very limiting. It's a good study, but it's limited.
I think I've had that test before, blood test. Is it called fluffy too? Is soft and fluffy the same?
Yes.
Okay, so they want you under 1,000, right? Is that right for that particular? The fluffy was.
So
I feel like I've had that test before, and I was at a 0, but now I'm at like 80. But it's the fluffiness of.
Well, that if you had a coronary artery calcium, what it's picking up is calcification. Essentially, if you've ever had have anybody that had a fracture and they developed a callus and then it turned to bone, pretty much that's what that is. So the calcium gets in there and it's turned into bone inside the blood vessel.
So you evolved. You probably had fluffy plaque that then calcified, and you got a score of 80. Is that what you were saying? 80? Mm-hmm.
Yeah.
Mm-hmm. Okay.
The calcium score is mostly from a CT scan of your coronary arteries, correct?
Yes,
Correct.
Dr. Faye.
Yes.
Mm-hmm.
Oh, okay. It's not a blood draw.
Right.
It's a CT scan.
Oh, gotcha.
So some of these tests we've talked about, the ApoB, the F2 isoprostane, that's a lifestyle marker. We get that just to see, in the beginning where patients are, and because what did I say? Lifestyle contributes to our development of disease by the tune of 80%. So if we choose a quality lifestyle, then we're at less risk. The highly sensitive CRP and the oxidative LDL, those are what we consider to be, along with the MAC and the ADMA and fibrinogen. These are what we call smoke detectors, such that if they are elevated, it certainly buys us some time to work with the patient, meaning work them up, but we certainly don't want to sit on our hands and procrastinate. If, on the other hand, the fire alarms, we call this the plaque 2 and the MPO, if those are elevated, that's an urgent call to action, particularly on that CIMT ultrasound if we do discover soft plaque. So again, if you have soft plaque, and if these fire alarms, one or both, are elevated, you better come see us. Well, you're seeing us. And then, of course, y'all have heard about troponin. That's measured, like if someone comes into the ER the classic clutching of the chest and, blah, 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 and they do some blood work. A lot of times that troponin will be elevated because that speaks to heart muscle damage. Okay, this is me. And when we were at the first health fair in January, so these are all my genetics. This one's, I'm going to turn that to green because I forgot to tell Dr. Jack I'm okay here. But look at this. I've got the APOE4. I told you I'm at a greater chance for developing Alzheimer's disease in my lifetime, so I better get my act together, right? Yes. I've got the haptoglobin. That tells me that if I eat gluten, not only will it cause some GI issues, but it will cause systemic all the way around inflammation, particularly in the walls of my arteries.
And so getting to the question that somebody asked about, can you tell where genetics came from? So the haptoglobin Tues, they pretty much came from Western Europe and migrate. So almost 80% of the United States is going to probably have one or two of the copies of the haptoglobin gene.
So I have one of the copies of the heart attack gene called the 9p21, and if you do have the 9p21 genetic marker, the heart attack gene, you're also at risk for an abdominal aortic aneurysm. That's just a weakening of the wall of the great vessel that comes off of the heart, and sometimes it's so weak that it can rupture and can cause pretty instantaneous death. So we always order an ultrasound of the abdominal aorta to rule out an aneurysm. And then I've got the atrial fibrillation gene, which puts me, I know, right? If I didn't have Dr. Jack helping me with my lifestyle, I wouldn't be here before you tonight. So people who have the AFib gene, we are at greater risk for developing a stroke because what AFib is, it's a very rapid rate, but it's also irregular, because you can have tachycardia where from beat to beat it's very uniform, but it's greater than 100. But with AFib, it's greater than 100, but there's no rhyme or reason. It's just chaotic. And so that causes turbulence in the blood flow, which could then set up a blood clot, which could go to the brain and cause a hemorrhagic stroke. But I don't have any plaque. Yay, right?
Yeah, and she does have some cholesterol issues. She's got elevated cholesterol, but that doesn't necessarily mean that it's causing her a problem. And we know that her lifestyle is helping because her ApoB level is
good.
Really good range.
Mm-hmm.
So
yeah. So when it comes to plaque, this individual has plaque, and it's a he. Yeah, David. He's got all this genetics. He doesn't have the AFib gene, but we've got to work on a whole lot of this red. So anything in the red is quote bad. Anything in the green is considered quote normal or well controlled. So he's a new patient. And so all the yellow means we got to continue to work him up. So
he's got plaque, but you also notice that his Lp(a) his plaque 2 is elevated, so he is on fire. And we also know that he's laying down cholesterol in the blood vessels because his ApoB is over 100. So we would like the ApoB to be less than 70.
So when our patients come in and they've had the ultrasound and they've had the blood work, we put together in the beginning of our evaluation of the patient their initial root cause tree, and then we go through this investigation, and at every milestone you'll see that transformation of the root cause tree, and a lot of this red will turn green because we get control.
So now I'm about to bring up a difficult subject for a lot of people, and it was a difficult subject for me because back 30 years ago when I was treating, orthopedic cancers, I would get a lot of people coming in. They were referred to me for what's called a soft tissue tumor, and there were certain things on an MRI scan that I can look and I can tell what it is. But I would get these people coming in, and I'm looking at it, and I'm like, that's not a cancer. That's dead muscle. So I walk in and I go, how long have you been on a statin? They'd say, about 6 weeks, because so these people were getting hit with high doses of statins, and nobody was checking their livers, nobody was checking anything, and then they're showing up for me for a possible cancer when it's a dead muscle. And I'm not really sure that we've made a whole lot of changes with that, because what our colleagues are chasing is the LDL.
Yeah.
I just
Yeah.
had a client last week with that going on. They wanted to palpate what muscles were gone, basically.
Right.
Big
Mhm.
and stuff.
50% of individuals who either suffer a heart attack or a stroke have normal cholesterol. Cholesterol is not the enemy, it's a factor. The enemy is what Monica said earlier, inflammation, and particularly inflammation in the wall of the arteries.
So statins were really never developed to treat cholesterol. They were developed to quiet inflammation and oxidative stress. One of the benefits was that it impacted LDL and cholesterol. Well, we know that if their cholesterol is better than their LDL, then they're taking the things. But that's not the reason why we use it. And if we can heal the inflammation, totally different from a lot of our colleagues, you may not have to stay on the statins. But the statins reduce oxidative stress. Part of the way they do this is they increase nitric oxide at the endothelial level. So what are other things that can increase nitric oxide at the endothelial level? Cacao will, because it's an antioxidant.
Beets.
Red wine will. Beets will. But that's one of the benefits. And it does a few other things, but the most important thing for us is once you start a statin, particularly the statin that we use, it will quiet inflammation within 24 hours.
Mm-hmm.
And so that's our goal, and particularly if there's an elevated ApoB.
Mm-hmm. Next. I think that's enough on that.
So we want to reduce oxidative stress. We want to reduce the ApoB level. We want to improve the smooth muscle. We want to reduce inflammation within the plaque and hopefully heal it. And then by reducing the inflammation, what we're doing is not treating the LDL or the cholesterol. We're trying to heal the plaque and keep it from rupturing.
Mm-hmm. Mm-hmm.
And then what it really does is, when it heals, it actually causes calcification. So then our patients are going and they're getting a repeat coronary artery calcium score, and they're going up, and the doctor's going, well, you got a problem, we got to put you on more, not understanding that it's healing the darn plaque.
Mm-hmm.
I had one guy come to me one day, he said, yeah, I started on a statin and my calcium score went up to 800. I said, that's a good thing.
It really is. And anytime we choose to put a patient on a statin, we use a couple of those genetic markers. But more importantly, we are kind of snobs now that we only really use one statin to defy the inflammation and to help that soft plaque undergo its metamorphosis to calcified plaque. And we never put a patient on that particular statin without putting them on coenzyme Q10 in the correct form.
And that's where I said the change in the LDL is not a predictor. It's just that we know that they're having compliance.
Hey, Dr. Jack, go back. I love this statement here that was bold. They even did PET scans and they showed pretty significant reduction in inflammation within 12 weeks.
So and what's nice, so the statin that we use is rosuvastatin, and there's some reasons for that, and that's called Crestor. Most of the patients that I saw who were coming in with dead muscles were on Lipitor or atorvastatin. And, you know, one of the things that we're worried about is the fact that it can cause muscle fatigue, muscle aches and stuff. So we can actually start somebody on a low dose. Some people will start them on a 2 milligram versus, there's a 5 milligram tablet, but it's really small if you try to cut it into 2 milligrams. But we can either do a Monday, Thursday regimen or a Monday, Wednesday, Friday, and give them a holiday so that they don't necessarily get the thing. But we also add ubiquinol, and so there's two forms of coenzyme Q10. There's ubiquinone and there's ubiquinol. For anybody over 40, it probably should be ubiquinol because of the methylation issue. So if you're taking ubiquinone, it has to be methylated into ubiquinol, and that's a challenge for people over 40.
So we use the terms rosuvastatin or atorvastatin. Those are the generics. So rosuvastatin, the brand name is Crestor. Atorvastatin, the brand name is Lipitor.
And studies have shown that
Lipitor.
Lipitor has never reduced the risk of a heart attack or stroke in a woman.
Particularly in women.
Wow.
Mm-hmm.
There are studies also that show that women, menopausal women put on the statin, which I guess is probably more Lipitor, are 4 to 5 times more likely to become diabetic.
Because it worsens insulin resistance.
So rosuvastatin goes through a different pathway than most of the other drugs. What they're designed to do is kind of slow down the transport of cholesterol to the liver, and so it won't worsen insulin resistance, whereas Lipitor will. But there's one other genetic test that we can do, which is called the SCLO1B1, and that tells you how you transport statins in the body. And so if you happen to have 1 or 2 copies of that probably means that a statin is really going to impact you. And so like Karen was bugging me, you know, so I still have to work this out, but I tried Crestor back in January for about a week, and then the second week I said, I can't take this. I said, I don't know what in the world is wrong. I said I exercise like crazy. I said I'm just having aches like I've never had. So I stopped it, and then I did the genetic test, and I'm okay on that part of it. So I could go back on the Crestor, but if you have low vitamin D, it will impact Crestor's availability and can cause issues. So it's a complicated science. But the most important thing is find a physician who will listen to you, and
Have you considered red yeast rice, which is the alternative?
it's up in the same category as
Statin.
Lipitor.
Right, but you don't get near the side effects with red yeast rice. You still want to take CoQ10 twice a day,
Right,
which
but
most doctors don't. even
for
tell
me,
people.
based on what I know about red rice yeast, and I've taken it before, it is not from a standpoint of causing side effects, it's just the same as Lipitor.
And the other thing is that when there were studies done, humans, not laboratory rats, there's a study called the Cafe Cave study that was published in 2008, comparing the benefit or the efficacy of Lipitor versus Crestor as it relates to quieting inflammation and controlling soft plaque. Red yeast rice was not part of that study, so we don't know the impact of how beneficial it would be to control inflammation and soft plaque. But some patients really push back on us and say, I don't even want to take the rosuvastatin, can I take the red yeast rice? And of course we say yes, but
it's going to go through the same pathway that Lipitor will.
and the most important thing is, if that's the case, it's going to act like impacting insulin resistance.
I mean, I was taking red rice yeast, but when I did the research, I was like, if it's got the same side effects as Lipitor, it's not something I'm putting in my body. But that's my choice. That doesn't necessarily mean it's somebody else's choice. So, I mean, our goal for our practice is we want to meet the patient where they are. The patient is the controller of their body, and so we'll do whatever we can to help. But I'm only giving you that answer because of what I've studied. So.
Mm-hmm.
I wonder how your blood type O's would react to like a red yeast as well. Sometimes blood type O's don't like some of the yeast products.
Right.
My body doesn't like it at all.
Mm-hmm.
Are you able to get them off the statin at some point? Once you get their blood markers down, you get them optimized, can you reduce it?
Yep.
to them
So our goal is to heal the plaque. So if we can heal the plaque, if we can improve the ApoB, you know, and now it may take a year or two for plaque to really heal, but we have seen patients, and so once we get them to that, we can either take them off, or if we have them on a medium dose, we can drop the dose.
So we tell.
Are you going to
yeah.
talk supplements in this presentation, or? I'm just curious, like, are
Maybe
y'all
we could
liking
do that
fish
at
oil
the
and-
at the health fair.
Yeah. Are y'all
'Cause-
liking like fish oil or antelope?
All right. So
What you were talking about here?
yeah. So it's interesting that you asked me that question, because I did some research over the last 24 hours, partly because I'm ApoE2, you know, I have a little bit of an elevated glucose. I probably should be on Crestor, but so for me, I need pure EPA without DHA.
Okay.
So trying to find, so that's either going to be Vasepa, which costs a fortune, or it's going to be the generic version, which costs a medium fortune. And then Nordic Naturals allegedly has one, but I can't really find it yet. But I need a pure EPA, whereas Karen, as an APO4, will benefit from EPA DHA, and it needs to be in about a 2-to-1 ratio for the EPA to DHA.
How about some little bit of berberine for your blood sugar? Because I'm having real good results with that.
He's on
With
it.
you know, consistent metformin, and we don't have the B-vitamin issues.
Right.
with berberine.
So my ApoB was elevated in November, so I've been doing two tablets of berberine twice a day, and my ApoB was normal last 2 weeks ago.
It lowered you too much?
It lowered my ApoB.
Oh, it did?
I still haven't figured out why my glucose didn't go down.
So I carry Nordic Naturals in my store,
Okay.
and I have that EPA, and I also carry berberine.
Excellent. Yeah.
Okay.
Good. So
You have the pure EPA, the Nordic Naturals pure EPA? Okay.
Yeah.
There you go.
that's it.
Awesome.
Any-
Awesome.
Thank you.